You're listening to Vet Synapse, a podcast connecting the world of research, innovation, and practical help to the veterinary profession. I'm your host, Dr. Philip Judge from Vet Education. Let's get connected with Vet Synapse.
Phil, today we're going to be talking about blood lactate, and you've chosen this topic to bring to us from your ECC background. Why is blood lactate such an important thing for us to be talking about?
Well, look, I guess blood lactate's one of those things that we measure quite frequently in both emergency as well as critical care medicine. And for many, many years, most of us have been taught in veterinary school and at CPD events that blood lactate equals anaerobic metabolism. And it's really, really interesting because as a result of that teaching, we're taught the higher your blood lactate is, the worse the degree of hypoperfusion your patient actually has within their circulatory system. And so the more aggressively we have to manage that hypoperfusion in order to decrease the blood lactate and hopefully improve patient survival. And there's a couple of controversies around that we'll talk about in a few minutes' time, but it's really interesting that that traditional paradigm may not in fact hold true across the entire breadth and depth of the patients that we see within emergency and critical care. It may not necessarily affect how we treat our patients, but it might affect how we view our patients in terms of their prognosis and the sort of advice we give to our clients.
So lactate isn't as simple as what we thought it was, it sounds like.
You're quite right, Zach. I think like global or whole body hypoperfusion has for many years been thought to be the most common pathologic cause of elevated blood lactate in dogs and cats, and indeed humans as well. And it's been postulated that as plasma lactate rises, it does so proportionally to the severity of hypoperfusion, with the magnitude of that hyperlactatemia being proportional to the severity of the insult. Interestingly, the magnitude of increase in blood lactate's not been associated with its ability to be reversed, but it certainly is thought to be proportional to the severity of the insult or that hypoperfusion. But studies over many years, and I say many years because it's back in as far as the early 1990s, it's been suggested that blood lactate production is more a function of the severity of illness rather than global hypoperfusion. So we get the severity of illness, a massive increase in adrenaline or epinephrine concentrations in body tissues. And that increase in adrenaline or epinephrine in our body tissues increases or accelerates the production of pyruvate within our cells, far above the capacity of our mitochondria to be able to process that pyruvate into ATP. And as a result of that, we get this great increase in the concentration of pyruvate within our cell cytosol, and that pyruvate is shunted, or metabolism of that pyruvate gets shunted to form lactate within the cell itself. And that lactate can then be exported from the cells and is used as fuel in organs like the liver and the lungs and the brain and muscles and so on.
So it sounds like there's more to the production of lactate than just hypoperfusion. There is hypoperfusion in a lot of these cases as well. So how do we know what's elevating the lactate in our patients? How do we know whether it's hypoperfusion or whether it's the aerobic metabolism?
Look, that's a great question. And I think the short answer to your question is currently we don't have any idea of the relative contribution of a hypoperfused tissue versus the spike in lactate that you will get with an excessive or excess adrenaline or epinephrine release secondary to a stressful event or critical illness. So, the plasma lactate concentration essentially then becomes a marker of the intensity of the critical illness. It's related to the catecholamine release during critical illness, and also that sympathetic nervous system stimulation that we get as well as being related in some patients, possibly some patients more than others. You mentioned GDV, for example. So possibly in some patients also related to a degree of metabolic acidosis secondary to global or regional tissue hypoperfusion.
Phil, we've got a patient that comes into the emergency room or our general practice clinic, and we think it's a critical patient. It might have something seriously wrong with it. When do we decide to take a lactate measurement, and how do we do it?
The short answer to your question, when do we take our first blood lactate level? Really, as soon as you're going to be placing an IV catheter in that patient. So most of us will tend to go for a cephalic or saphenous catheter in our patients. You can grab a blood lactate sample or a blood sample for blood lactate analysis from that catheter site once you get your IV catheter in. Kind of as a little side note, there are some really interesting studies that have been carried out trying to determine whether venous blood lactate versus arterial blood lactate is a better sample. And we might as well talk about that now since I've raised it. But the upshot is that there is very little advantage over getting an arterial blood lactate concentration over a venous blood lactate concentration in pretty much any patient. In theory, the arterial blood lactate concentration is better because you get the sum of all venous circulation that's returned to the heart and is now in arterial circulation. Oxygenation of the blood as it traverses the lungs doesn't affect blood lactate at all. So in theory, your arterial blood lactate concentration is going to be superior to the venous blood lactate concentration. However, there doesn't seem to be much difference in blood lactate level, whether or not you use a central or a peripheral vein. The most important thing with regards to your sampling is that you use the same or similar site for each sample. So I wouldn't be getting a jugular sample for my first sample, then a hind limb saphenous sample for my second sample, and then an arterial sample for my third sample. What I want is consistency across those sampling sites. So that kind of, I guess, addresses that. But essentially, you want to try to get your first blood lactate concentration before you administer your IV fluids and many other interventions to your patients.
In terms of measurement options, arterial, venous, it doesn't really matter. But you talk about consistency being really important there.
Yeah.
What about the machine that we use to actually measure the lactate? What are our options? Do we need to go out and buy a new machine, or can we use the stuff that we've already got?
The key thing is consistency again. So if you start off measuring a blood lactate concentration in a patient on a handheld machine, use that same machine throughout that patient's hospital stay. Likewise, if you're using a benchtop machine, and likewise if you're using a reference laboratory. Granted, these cases, as in many complicated things that happen in veterinary practices, usually happen on a Friday evening. So you may get your first sample read from a reference laboratory, and in subsequent samples, you might have to use your handheld or your benchtop machine within your clinic. And that's fine. Just recognize that there may be different reference ranges and different, slightly different methodologies within the biochemical measurement for lactate between those. And so your first two samples, if you're using two different machines, might reflect slightly different methodologies in the measurement. So you may not be able to compare apples with apples in those, but the key really is consistency. There is certainly nothing wrong in using a small handheld lactate monitor or a benchtop monitor within your clinic. Just be speaking with your local suppliers to see what the best options are in terms of their particular analyte, based on whichever machine you've got from a Baxis or IDEX or whatever.
Phil, you mentioned a couple of times that lactate can help you when you're talking to the clients and you're trying to figure out how your patient's doing. How useful is it as a prognostic indicator? Is it the be-all and end-all, or is it just another tool in our arsenal? And how good a tool is it?
I think it's a really useful tool. I like your statement, is it another tool in our toolbox? Because I think it is. It's one of those things that we can build into our arsenal of clinical signs, other laboratory results, to be able to communicate more effectively with our clients about how their patient is doing and what we expect from that patient within the next 6 to 12 hours. And it's really important to note that, as we've mentioned before, it's the serial blood lactate concentrations that are the most helpful when we're trying to apply blood lactate to prognosis. To date, in dogs and cats, the majority of the studies on blood lactate have been related to the relationship between blood lactate and prognosis. And so let's take, for example, in systemically ill dogs, there was a couple of studies. The largest only involved about 80 patients, and they looked at blood lactate concentrations on admission and then at 6 hours after commencement of treatment. And then they compared those lactate concentrations against survival out to 2 weeks following admission for treatment of a whole range of illnesses. There was vomiting and diarrhea, GDV, pancreatitis, and a whole range of other things as well. And what they found was that lactate concentrations above the reference range at time equals 0 were not related significantly to outcome, which means that a single elevated concentration of blood lactate does not mean that your patient's going to die, okay, in that particular cohort. And then there were varied illnesses in that cohort. But what they found was that if that hyperlactatemia did not improve by greater than 50% at the 6-hour mark, that was significantly associated with higher mortality. And the dogs with lactate concentrations that were greater than the reference interval or reference range at 6 hours were 16 times more likely not to survive their illness compared to dogs with lactate concentrations within the reference range. So 2 really important things came out of that study. And the first was that a single elevated blood lactate concentration in a critically ill dog does not mean your patient is going to die. So, in our professional lives, it's really important that we adhere to that and don't prematurely condemn a patient to a conversation with an owner that might sway them towards euthanasia because of a single blood lactate concentration. And the second thing is that it seems that a 50% reduction in blood lactate at the 6-hour mark is more significantly associated with mortality if your patient doesn't have that 50% reduction in blood lactate than if they do make it. Moving on to GDV, there was a landmark study done in 1998. It was a retrospective study where they looked at the relationship between plasma lactate concentration and gastric necrosis. And they found that an elevated blood lactate concentration was predictive of both gastric necrosis and prognosis of dogs with GDV. The really important thing about that study was that they had no follow-up or serial measurements for blood lactate. So they weren't actually able to track what happened to that patient's blood lactate after admission in that hospital. Subsequent to that study, there was another study carried out in 2011 that looked at admission blood lactate levels and lactate levels at 12 hours after admission. And what they found was that if your blood lactate level was greater than 6 millimoles per liter, it did not accurately predict gastric necrosis or survival in dogs with this study. So that directly disagreed with the first study we just mentioned, in that they used a lactate cutoff of 6 millimoles per liter and found there was an association with gastric necrosis. In this study, they found that there was no association between macroscopic gastric necrosis or survival. And additionally, they found that a decrease in plasma lactate concentration of greater than 50% within 12 hours of admission was a good indicator of patient survival to discharge. So what I think these 2 studies illustrate is, again, that serial lactate measurements are much more likely to be accurate in predicting outcome and prognosis in GDV, and it's not recommended that decisions on preoperative euthanasia of dogs with GDV be based on the degree of lactate elevation from a single sample. And it brings us right back to what we said before about the importance of serial samples.
You have a patient in hospital that's been doing all right and it's come in with some vomiting, some diarrhea, where managing it conservatively. At what point do you think getting a lactate is useful in those hospitalization cases? Or is it something that unless you get it at the start, it's not really going to give you as much information?
I think that circles back a little bit to what we were talking about before, that I think if you have a patient who perhaps is admitted with relatively mild or moderate disease, maybe you're on a busy shift, or the machine that you're using is not not being helpful for you in terms of getting a reading, or you don't have significant enough blood sample from that particular patient, and 6 or 12 hours later that patient is looking worse, I do think it is valuable in obtaining a blood lactate concentration, even if you haven't got one at time equals 0 when that patient presents to the hospital. Because the key thing about lactate is a trend. And so once you get your sample, you can then monitor that trend in 2 hours or 6 hours or 8 hours, whatever the time interval may be. And you can get an idea from that as to whether or not your blood lactate level is falling or not. And there are numerous studies that outline a strong correlation between blood lactate levels falling in your patient and improved survival. So I don't really think that while in an ideal world, it would be great if we got a blood lactate concentration from our patients right at the start of treatment before they've had any interventions. There is nothing wrong in obtaining a sample 2 hours later or 6 hours later, as long as you're using samples to monitor a trend in blood lactate.
So we've got our patient come in and it does have a lactate that's high. What do we start doing to treat that patient? Obviously, we want to treat the underlying condition, but what are some things that we need to be looking at in order to bring that lactate down and get it down that 50% by 6 hours?
So the efforts to treat high blood lactate really are directed at effectively managing that underlying cause, just as you said, rather than chasing the lactate itself. If we go chasing a particular number and trying to normalize a number, invariably we'll fail because we'll forget a more holistic approach to patient management. And so, for example, a patient with pancreatitis, for example, I choose pancreatitis because it's a fairly common disease in dogs, and it can turn really nasty, and patients can develop sepsis and really high blood lactate concentration. So let's take this hyperlactatemic patient with pancreatitis. How do we manage pancreatitis? We manage the patient with intravenous fluid therapy to restore normal blood volume and hydration. We rectify abnormal electrolyte concentrations in our patients. We give our patient appropriate analgesic therapy. If our patient develops septic shock and they develop severe cardiac arrhythmias, we manage those abnormal cardiac rhythms with whatever drug is appropriate. Continuous infusion for ventricular tachycardia, for example. We treat hypertension with vasodilators if our patient is in a hypertensive state due to sepsis. We treat hypotension using vasopressors. We treat poor cardiac output, and that's perhaps a subject for another podcast on how do we treat or how do we diagnose and treat poor cardiac output. But a lot of these patients that are critically unwell do have myocardial dysfunction resulting from compounds like nitric oxide, for example, which is a negative inotrope that's in massive concentrations in our patient's circulation in sepsis. So in those particular patients, we're going to use positive inotropes to try and improve cardiac output, normalize blood pressure, normalize blood volume, and so on, manage pain, electrolyte abnormalities, and so on in our patient. And if we do those things well, our patient's blood lactate concentration frequently comes down. And this gets back to the notion that blood lactate concentrations are related to illness severity and adrenaline sympathetic nervous system stimulation. So if we adequately manage the underlying disease, the blood lactate concentration can end up correcting itself. It's a bit like blood gas abnormalities, metabolic acidosis, for example. If you just go chasing the metabolic acidosis and forget to treat the underlying disease in your patient's probably always going to have this metabolic acidosis associated with this condition until we get everything else associated with our patient's organ systems, renal perfusion, gut perfusion, nutrition, cardiac rhythm, cardiac output, blood pressure, and those sorts of things. Until we manage those things appropriately, our patient's probably going to always have these serious abnormalities in terms of blood gas and lactate.
So we're taking a blood lactate in our really critically ill patients, the GDVs, the acute abdomens, the patients that are really on death's door. Are they the only patients we should be taking it in, or what other cases should we be thinking about taking a lactate in at the start of hospitalization?
Great. That's another good question. Look, you've nailed the big ones that we're going to be using lactate for most frequently. In a number of human and animal studies, they've actually looked at blood lactate concentrations and lactate concentrations of fluids in a number of other diseases. For example, in humans, CSF lactate is able to differentiate septic from aseptic meningitis. There was another study looking at lactate concentrations in pericardial effusions. There was a clinical study that looked at levels of pericardial fluid and comparing them to peripheral blood in patients with pericardial effusion, and they found the pericardial fluid had a higher lactate concentration than serum lactate concentrations, and they found that neoplastic effusions had a higher lactate than non-neoplastic effusions. And there was a bit of a buzz a few years ago when this first came out in this particular study, thinking, well, if my pericardial fluid has a higher lactate, maybe it's more likely to be cancer, and that may help direct my discussions with the clients. But it's interesting that study had really, really poor specificity for that particular finding of neoplasia. So it's really kind of precluded its use in routine differentiating of neoplastic from non-neoplastic effusions. So not terribly helpful at this particular juncture. The majority of the other uses for blood lactate have been in cases of GDV, systemically unwell dogs with sepsis, septic peritonitis, for example, babesiosis, and peritonitis in dogs. And then cats. Cats are an enigma in a number of diseases, including pancreatitis and so on. There was a really interesting study looking at 102 cats that required IV fluid therapy for management of illness, and they found an admission lactate of greater than 4 millimoles per litre was associated with a survival rate of 63% versus a survival rate of 91% for patients with blood lactate concentrations of less than 4 millimoles per litre. So they equated higher lactate concentrations with higher mortality. They were also associated with longer hospitalization times. Additionally, they found a decrease in lactate of greater than 30% within 8 hours. Notice that's not as big as what we'd expect with a GDV patient, for example, where frequently we see 70 or 80% decreases within a couple of hours. So this is a decrease in lactate concentration in cats of greater than 30% within 8 hours of hospitalization was associated with a much higher survival compared to cats who had a decrease in lactate of less than 30% over the same period. So going back to, I guess, how frequently are we going to take our blood lactate concentrations? For dogs, maybe 1 to 2 hours in the acute period, maybe every 6 hours in a patient who's perhaps in hospital. For cats, it seems that 8-hour period is the one that kind of helps us a little bit further along the track in terms of trying to differentiate survivors from non-survivors. And cats are very interesting because they don't have the same kind of dramatic presentations that dogs do. A dog with pancreatitis comes in with vomiting, abdominal pain, clear dehydration and lethargy. A cat with pancreatitis can look completely normal and may have just gone off its food. It may not even have abdominal pain, and yet it can have quite serious inflammatory disease in its abdomen. So I think in cats we have that, I guess, seemingly less urgent clinical presentation, but a really useful use for blood lactate concentration in terms of trying to determine which way our cats may be going. And I think when we translate that to discussions with the owners about how well our patients are doing, that can be quite important.
Phil, it's been a pleasure having you on this episode of the Vet Education Podcast. I look forward to having you back another time.
Thank you very much, Zach. Thank you for listening to this episode of Vet Synapse. If you like this episode, please subscribe to the podcast and share it with your friends and colleagues. Make sure to visit our website at veteducation.com.au for more great content and to experience the latest online race-approved veterinary continuing education.